Good afternoon, everyone. So I'm Toby Ferguson, and I'm substituting for Bob Bowser. And today, for the ending session today, we have a little bit different approach. We're going to have a sort of fireside chat. Imagine the fire in the back. Around what are sort of the key biomarker questions and challenges. And really, we're going to sort of have a panel of experts sort of talk through that topic, and then we'll have some time for Q&A at the end. So with us today, we have Danielle Graham from Biogen, where she's the head of Biomarkers. Michael Benatar, who's the chief of Neuromuscular at the University of Miami. And we have Nick Ashton, who is the senior director at Banner Health and done a lot of work in biomarker assay development, in particular, both in ALS and Alzheimer's. So I think with that, I've got a few questions just to get us started. I'll ask an important but general question to start. And maybe each of you in turn, maybe starting with Danielle and just going down the line. How have biomarkers transformed the clinical landscape?
Sure. I have to start first by saying thanks to Toby, but also to Amy and the rest of Target ALS for the opportunity to be here. Very excited to be here and talk about my absolute favorite topic, which is biomarkers. So I'm going to describe for you how biomarkers have changed the clinical development landscape using tofersen as an example. And I just have to add that tofersen is the name of Qalsody, sitting next to Toby Ferguson, who many of you might know the name the drug was named after, which I just find hysterical. But many of you are probably familiar with the data readout from the tofersen pivotal study, which was VALOR. And when that study read out, we did not have statistical significance on our primary endpoint. It was only after we went and looked at neurofilament and looked at the baseline levels of neurofilament that we identified that there was, in fact, clinical benefit. But in addition to, so I will be talking a lot about neurofilament as a tool that has enabled success in clinical trial development in ALS. But it's important to remember that with the tofersen example of success, it wasn't just neurofilament. It's a combination of multiple things. So in the tofersen pivotal trial, we saw steady state PK levels at about 4 weeks. We saw a reduction in CSF SOD1, which told us about target engagement. So we actually had an impact on the mechanism of the drug that we were evaluating at about 8 weeks. And then we saw changes in neurofilament at about between 12 to 16 weeks. And I just want to emphasize one more thing about the neurofilament piece. We saw changes in neurofilament, phosphoneurofilament heavy and neurofilament light, in blood, plasma, in CSF, and on 2 separate matrices. So it was a very robust effect on neurofilament. And as a result of that change in neurofilament, we really did advance the use of neurofilament as a treatment response biomarker. So neurofilament can be utilized to reduce heterogeneity at baseline, but also to tell us if a drug is having clinical benefit. And so that's one of the main things that I think has changed in the neuromuscular, in the ALS clinical trial landscape. Internally, we're actually utilizing neurofilament to help guide early clinical trial decisions on whether or not a drug is having an impact on neurodegeneration.
Michael, maybe with some, I know you'll mention neurofilament, maybe with some comments on pre-symptomatic.
Yeah, before I come to pre-symptomatic, maybe just to sort of clarify the question, because I think you'd sort of asked about how biomarkers are transforming the clinical landscape. And I wanted to just make a little bit of a distinction between the clinical landscape, maybe the clinical trial or therapy development landscape, the research landscape. Because a lot of the learnings that are coming out of clinical trials are sort of group-based, right? So what Danielle described in the VALOR study are looking at group-level reductions in neurofilament that we're interpreting as reasonably likely to predict a clinical benefit. And we do have to be cautious as clinicians as we move those observations into sort of the clinical realm and use them at an individual level. There are some nuances there that we should perhaps be careful or circumspect or cautious about. But on the pre-symptomatic front, I mean, I think as this group well knows, we found that levels of neurofilament light, also phosphoneurofilament heavy in both blood and CSF, go up in advance of people phenoconverting to clinically manifest disease. And those observations were initially made in an SOD1 population, primarily a population of carriers of highly penetrant, very aggressive mutations. And we've now used that together with Biogen in the ATLAS trial as a susceptibility risk marker to tell us that phenoconversion is coming in the not too distant future, and to randomize people into drug or placebo to see whether it's possible to delay the emergence of clinically manifest disease or even potentially prevent it. But I also want to add the caveat there that neurofilament may work well as a susceptibility risk marker in people with SOD1 mutations associated with rapidly progressive disease. And I think it will be an important marker in other genetic forms of disease, but not as a standalone. And so again, there I want to make a distinction between individual and group level observations. So when we observe that on average, people with C9, for example, have higher neurofilaments than age and sex match controls, that's not the same as saying we can use that at an individual person level as a susceptibility risk marker to predict the emergence of disease. And maybe we'll come back to that, but I'll pause there.
Thank you, Michael. And Nick, I want to give you a chance, but maybe to change the focus slightly, we heard some very early in the day, heard some excellent talks from Pietro, Michael, and Len, and you've certainly worked on that effort. Could you comment a bit on more the potential of those sort of antibodies and assays you're working on to help us think about other forms of ALS?
Yeah, so I draw a lot of parallels of what we've been doing with these cryptic peptides to where we were with phospho-tau a decade ago. So I remind you that in 2018, 2019, we couldn't even measure phospho-tau in blood. We didn't think it was an option. Assays improved, understanding of what antibodies we should develop improved, and now it's very, very commonplace. And I see great parallels with this, is that we have better antibodies, we have new technologies, and you started to see some data today that we could start detecting these cryptic peptides more consistently. I think the book is still open whether that's important, but now we can detect them, we should be able to understand a little bit more about the heterogeneity of these cryptic peptides, and hopefully adding to that list. So, is there a profile of cryptic peptides, not just one? So I think that having, as the technology advances, as we do this in more patients, is it more prevalent in C9, sporadic? These are all questions we can start to answer now. Just like with phospho-tau, where it's become so easy to measure that biomarker, you have to remember that this has all come in just a decade, from not being able to detect it at all to being able to get a measurement result on a Roche instrument within 10 minutes. That's happened in 10 years, so I think we can look forward to doing that in this space as well.
Yeah, no, I think if we can't measure it, we can't understand it,
Exactly.
and having the tools is crucial. So excited to see where it goes. Maybe turning a little bit more future-oriented, and maybe Michael, I can start with you. What do we still need, and for what use cases in terms of biomarkers generally in the field?
Yeah, so we could probably talk for an hour on that, but let me try to be brief. I mean, I think one of the biggest challenges we still face in biomarker development, and although we talk about this a lot, I'm not sure we're hearing ourselves, that we really need to think about sort of the context of use. What is it that we want the biomarker for? Do we want this as a diagnostic, and that's a hobby horse for me, that I think often we're putting things up as a diagnostic which really aren't or won't perform in a diagnostic setting? Do we want something as a susceptibility risk? Do we want it as a prognostic measure? Do we want it as a response measure? And the same marker can serve multiple roles. NFL does do that, but we have to be crystal clear, because the data we need for those different purposes is really very different. Sometimes we can use it at a group level. You want a response marker, well, the treatment group, the level of whatever the marker is, goes down. You want to use it as a susceptibility risk marker, it's got to work at the level of the individual person. That requires a different level of fidelity. And so I want us to collectively think hard, whatever biomarker it is we're developing, there's obviously the technical aspect of being able to measure this accurately, reliably, understanding the pre-analytic and the analytic conditions. But beyond that, we have to think about the application and how it's going to be used and what data we need.
Danielle?
Yeah, I was just going to add on to that. So I obviously work for a pharmaceutical company. I'm in the business of developing drugs. And I say all the time what Michael just said, so I feel like he stole my thunder. Because the context of use, the intended use, asking yourself, how is this biomarker going to be used, is the first and most critical question. But I want to add on, Michael referenced a number of different categories, but he also referenced treatment response biomarkers. we have to be very clear. There's more than one treatment response biomarker. So in the context of drug development, in addition to showing a treatment response on something like neurofilament, you also need to show a treatment response on a method, a measure that tells you whether or not you tested the hypothesis of the drug that you are going after. And so I'm going to use the C9orf ASO example, again, from the Biogen clinical trial space, where we targeted C9 ALS with the C9orf 72 ASO. We did not show any sort of clinical benefit, but we showed very robust reductions in GA and GP in the CSF. So we concluded from that trial that we did, in fact, test the hypothesis, but it resulted in no change in neurofilament and no clinical benefit. So it is absolutely critical when you're thinking about additional biomarkers that we need. We do need risk susceptibility biomarkers. We do need biomarkers that tell us about progression. But we also need biomarkers alongside the development of novel targets to tell us about whether or not we've tested that mechanism.
I couldn't agree more. Nick, anything to add?
No, I think both Michael and Danielle have described it perfectly well. We need biomarkers in all aspects, and we can't expect one biomarker to do every single job. One thing we've learned also is that just because a biomarker is available doesn't mean we should start using it in every single person we can get our hands on. This is the issue we have now of Alzheimer's disease. We have such a great biomarker. We're really struggling about where to place it. Should we be using it in pre-symptomatic individuals? Should be using it as a response biomarker for anti-amyloid? It doesn't look like it's a good biomarker in that context. So I always joke that we've been congratulated for the last decade for creating these assays, and then the last 6 months apologizing for them being existing, because we're really struggling about what is the responsible use of this one biomarker that we have that works very well, but only works very well in certain contexts.
Can I add one more thing on this
Please,
topic?
please.
And I'm actually going to ask Michael for his view and Nick yours as well. So biomarkers is an iterative field, right? And you're going to develop a new assay, and it's going to be appropriate at that moment in time. But these things evolve. They get better, they get worse. And so another really important thing about the evolution of biomarkers is that you're staying aware of and on top of the performance of the test. And I'm actually going to use examples that we have had within Biogen, where we started out looking at both phosphoneurofilament heavy and neurofilament light. But as the work progressed for the platforms that we were using, we pivoted away from heavy and are focused now more on light because of the performance of the test that we're using. And so it's absolutely critical to stay very diligent about the analytical performance and the understanding of the test that you're using, whether it's a target engagement biomarker, whether it's a disease progression biomarker, whatever it may be, and constantly make sure that your test, your biomarker is performing well.
I'm going to actually double down on that a bit. I mean, recall the conversations at Biogen when we were sort of getting data around heavy and light, and Danielle was saying assay characteristics are better. That contributed to the ongoing conversation and making neurofilament, in particular neurofilament light in the plasma, as a key secondary endpoint, very important and critical to that discussion was the assay performance. And it's that assay performance that then allowed us to convince the FDA that our measurements were meaningful. So it is a non-trivial point that you get the assay right, particularly in the context of a pivotal study.
But perhaps I can just add to that, more orthogonal as to what you're saying, but I don't know the inside of Biogen or the FDA, but I think part of their decision-making was also not just the analytic performance characteristics, but also the notion that we know that neurofilament is very prognostic of future clinical course. And so in a sense, it's these different contexts of use dovetailing, right? We didn't actually have data to say that you reduce neurofilament, ergo that leads to a better clinical outcome. That data comes, right? But it's the idea that high neurofilament, you progress quickly. Low neurofilament, you're progressing more slowly. And there's such a robust body of literature around that there's something very intuitive that if you lower that's very likely to predict a clinical benefit.
Exactly right.
We certainly agree. And as we think about new and novel biomarkers, if we think they have utility in predicting disease course and they're, say, separate from neurofilament, you have to ask very similar questions about each of those biomarkers.
100%.
So maybe pivot a little bit to TDP-43, and Nick, I'll start with you. We aren't there yet, and so the cryptic exons are one example, but what are the challenges and what are we going to go for this sort of set of biology?
So from my perspective, I think that and maybe people will disagree with me, but actually measuring the protein TDP43 or phosphatide TDP43 in the biofluids has not yielded any results, and I don't expect it to in the near future. We thought it may be an assay issue, more sensitive assays. They've come along, and we still see the same results. So actually targeting the protein related to the pathology in the biofluids is not yielding anything. So we are left with this loss of function cryptic peptides as our surrogate. I think where we really lack for TDP43 in general is a standard of truth. We don't know whether the pathology is there or not in other dementias. We expect it to be there in ALS, of course. But that's where we lack at the moment. Is our biomarker surrogate of TDP43 or not? And the data pool that we have to really test that is very, very small until these biobanks start to increase in size. So we are a little bit guessing at the moment. We have models and biomarkers of 20 panels to predict TDP43 at postmortem. They have their own problems. So I do think actually our best promise at the moment for a TDP43 biomarker is these cryptic peptides that the ALS field is leading.
Can I also add to that? So you said something that's really important, and I just want to emphasize it again. The existing measures in our hands as well, data that we've generated and that I've also seen published, the existing measures in the fluids for TDP43 or phospho-TDP43 are not differentiating between healthies and ALS patients. So they are not providing a useful measure of TDP43 pathology or TDP43 aggregation. But there is absolutely a critical need for this. And in fact, Chris, I don't know if you remember this, but maybe 6 years ago, you described TDP43, the biomarker TDP43, as the nut that we have not cracked as a field yet. And it is 100% true. But if we think about therapies and developing therapies that ultimately are going to impact TDP43 upstream or downstream, we need to see biomarkers of TDP43, whether that's a panel, as you were describing, Nick, whether that's pathology. So AC Immune is also developing a TDP43 tracer. Mm-hmm. They shared some data, I want to say it was at ADPD this last spring. But then TDP43 pathology and or measures of TDP43 aggregation. These are two areas that we have to continue to focus on.
So I'll give you a real world sort of pull through of that. The Ataxin-2 study in ALS, the ASO that did not work, we had probably reasonable target engagement, probably greater when you look directly in the cord. But did we impact the TDP43 biology as we hypothesize we do? We don't know.
That's right.
And it would be very important to try to understand, did we in that context? So maybe we have just a couple minutes left. Maybe a sort of structural question to each of you. What do we think the field needs? And this is more in terms of not scientific, but funding, research, approach. How do we sort of push to the next breakthrough? Maybe Michael.
It's a good question. I think, I don't mean to keep coming back to neurofilament, but I think we have in neurofilament a powerful prognostic marker. We have powerful clinical prognostic models sort of encapsulated by something like the NCALS prediction score. We know adding the two together is more powerfully predictive. I think if we want to go after additional prognostic markers, we have to show that they do better than or add to what we already have. I don't think we should spend time looking for things that are small effects that are less than the things that we have available, number one. Number two, on the pre-symptomatic front, I think we need things that are more and better than neurofilament. I think if we want to get beyond Atlas and the rapidly progressive SOD1 carriers, we need better risk susceptibility markers. And my hunch here is that there isn't one. We probably need a panel. We probably need an array of markers that we'll put together that collectively will sort of be a biomarker index of some sort. And if we want to get to prevention efforts in other diseases, in other genetic forms of disease, I think this is going to be essential. And maybe just lastly to say, if we want to really get to answer the diagnostic question, I think what we need is sort of a global effort to put together a population where the diagnosis is genuinely unclear, so that we can actually establish whether any putative biomarker that we test has value. But I think the diagnostic problem at the moment is less a biomarker problem and a sort of social health system issue. So maybe not appropriate for a biomarker panel, but I'll stop.
Fair enough. Nick?
I think there's two things we can be doing. One is immediate, and you know, we have great technologies around that can measure thousands and thousands of proteins, and some of them are going to be completely unrelated to the disease. But it's a low-hanging fruit that we can work on right now. We have bioresources with Target ALS and others, SomaLogic, Olink, Alamar. These are great panels that we can start looking at. And unfortunately, as you know, spoiled as this is going to sound, it doesn't make sense to do these panels in 20 versus 20 or 30 versus 30 because they're so large. You need to go, if you're going to use this for real, you need to go at it full hog and measure thousands of samples, which are available right here. So that requires funding, Target ALS. So the second thing is that in my experience in dementia, we've never actually found a diagnostic biomarker by going this way, right? It's always been driven by the neuropathology, seeing if we can do it in CSF, seeing if we then find it in blood. So I'm still very much trying to engage in basic biology about what are those key biomarkers, and then can I take that and start making an assay that works in tissue, then works in cerebrospinal fluid. So there are two different approaches. One I think we can do now and see if we stumble across something. I mean, Michael might want to say something about your preprint about, you know, different biomarkers adding something to neurofilament light. Two different approaches, one we can do now, one which is a bit more of a longer term.
Excellent. Danielle, last word to you.
Yeah, and I'm going to be super quick because we're out of time. I had a couple different thoughts, but I'm going to say one, and it's piggybacking off of what Nick just said. I do think that there is a need for continued investment in the biology, and as you're thinking about the biology, you're thinking about corresponding biological markers that can be biomarkers for subsequent trial development, whether that's telling you about just your target and your therapeutic, or that actually becomes something that might tell you more about disease progression or heterogeneity of the disease. But there's still a fundamental need for greater biological investigation. And that's all. Yeah, I'll stop.
Do we want to take 5 minutes for a few questions? Would the audience, should we do that? If there are questions?
If there are questions.
If there are questions. Okay. If no questions, then, oh, wait a minute. I have a couple.
Hi, Dr. Benatar. Could you speak about your thalamic imaging biomarker with Corey McMillan while we have a moment here?
I want to be sure I heard you. Thalamic?
Oh, I'm sorry. I just read these things. I don't know how to pronounce them.
Yeah, so this is some work we've been doing together with Corey McMillan at Penn, and sort of building on a number of observations in the field. Just the idea that thalamic volume seems to be a useful susceptibility risk marker in C9 carriers. I think we need some replication cohorts, and we need to be able to define thresholds. But it does seem that there is thalamic volume loss, perhaps above all other areas that we see pre-symptomatically. And maybe I should just clarify, I don't think that it's selective in the thalamus. I think there are characteristics of the thalamus from sort of an imaging perspective that make it useful as well. So it's a combination of what we can measure and where there's pathology.
Chris?
So I think we probably all agree that even in the absence of a huge suite of effective therapies, early diagnosis is a good thing to go for. And Michael, you were saying that we're not getting there partly for social reasons, and I think that's a real comment. And I think the social reasons may be because of the health systems and so on. But I also think, and I've said this internally at Target ALS, I think socially what we need is a group motivated about this to come together and to think about what experiments we need to do. And whether that could be it would need to be a long-term project, probably, but just what tools we would use, how we would ask the questions. Because I think it's just very hard for one group to come up with this. But I know there's a lot of support for the general idea at Target ALS, so I'm just echoing that, since it didn't come up as one of the main topics.
I'm sure there are people in this room, and I'll put my hand up too, we'd be happy to put together a consortium to focus on this issue if that's of interest to Target ALS.
Very good. Thank you very much, panel.
Thank you.
And if you have questions afterwards, please find us. Thank you.
Thanks, Bob.
Thank you.